sorry that I could not attend the meeting actively due to the pandemic conditions. I wish you a productive meeting and proceed to my presentation. In this presentation, I would like to talk about the role of radiation therapy in the treatment of primary central nervous system lymphomas. Epidemiology sorry.
Host not let share screen. Can you let us to share screen?
Sorry?
Any?
So, Dr. Meral,
Yes?
yeah, I already make you as a host. Yes.
Okay.
Yeah. Thank you.
The epidemiology, with regard to the epidemiology to primary central nervous system lymphoma are rare. The incidence has been increasing mainly due to various immunosuppressive situations, HIV infection, at iatrogenic immunosuppression following organ transplant, and congenital immune deficiency, such as included ataxia telangiectasia and Wiskott-Aldrich syndrome. And in addition, patients with autoimmune disease such as rheumatoid arthritis, sarcoidosis, vasculitis may be predisposed to develop either disease or therapy-related primary central nervous system lymphoma. And the incidence, immunocompromised patients are affected at younger age compared with immunocompetent patients. The overall incidence rate of primary central nervous system lymphoma is 0.47 per 100,000 person years, and the rate has continued to increase in men aged 65 years and older in women. About pathogenesis, we can firstly say that the central nervous system normally lacks lymphoid aggregates. The cellular and molecular events leading to neoplastic lymphocytic infiltration of the central nervous system is seen in primary central nervous system lymphoma, and molecular events. Three major issues need to be addressed to understand the nature of primary central nervous system lymphoma. First, the histogenic origin of the tumor cells. Second, the transforming events. Third, the role of the microenvironment of the central nervous system. However, the underlying molecular pathogenesis of primary central nervous system lymphoma has yet to be elucidated. But it should be pointed out that impairment of HLA-dependent immune surveillance may play an important role in primary central nervous system lymphoma development and characterization of genomic landscape of primary central nervous system lymphoma is in progress. Alterations that occur with high frequency in primary central nervous system lymphoma include biallelic cyclin-dependent kinase inhibitor loss and somatic mutation in immunodifferentiation primary response can. Yes, clinical presentation, the location of lymphomas in the central nervous system lymphoma, the initial presentation, inline series, patient with primary central nervous system lymphoma, focal neurologic deficits were found to be most common signs that was seen in 70% of patients. Other important complications include neuropsychiatric symptoms and signs of raised intracranial pressure and seizure and ocular symptoms. And presenting symptoms may include headaches, blurred vision, motor difficulties, and personality changes are most often associated with lesion of the frontal lobes, periventricular right matter, or corpus callosum. Visual hallucinations may result from infiltration of visual pathways or the brainstem or from ocular optomeningeal involvement. About evaluation, the baseline evaluation of any newly diagnosed patient with primary central nervous stem lymphoma should include a comprehensive physical and neurological examination. Age and performance status are the most widely documented prognostic variables and must be recorded in every patient. Evaluation of cognitive function is important at baseline, and follow-up assessment are critical both to determine the benefit of therapy as well as monitor for treatment-related neurocognitive decline. The ideal measure of cognitive function has yet to be determined, but would evaluate attention, executive function, verbal memory, and motor speed. Before the initiation of therapy, a careful examination for disease extension has to be carried out in order to perform an optimal treatment modality. The evaluation process of patients suspected having primary central nervous system lymphoma should include optimal imaging of the brain parenchyma, a gadolinium enhancing MRI scan. A lumbar puncture should be done to all patients for cerebrospinal fluid cytology unless medical contraindicated. Cerebrospinal fluid cytology should be sampled before and 1 week after surgical biopsy to avoid false positive results. A detailed ophthalmologic examination and testicular ultrasound may be considered in order meant to exclude an occult testicular lymphoma metastatic to brain. Evaluation and complete systemic imaging is warranted in every patient. Body positron emission tomography imaging may be incorporated into the evaluation of systemic disease. The diagnostic procedure of choice for primary central nervous lymphoma is a stereotactic needle biopsy. Because patients derive no clinical benefit from surgical resection and deep state nature of the most lesion increases the risk of surgical complication. In general, corticosteroid use should be avoided prior to biopsy, as these agents are lymphocytotoxic. Whenever possible, the tumor should be characterized by immunophenotyping. The treatment of primary central nervous stem lymphoma is known to be highly sensitive to both radiation and selective chemotherapeutic agent. High-dose intravenous methotrexate should be the backbone of induction therapy in most patients. The optimal consolidation therapy has not been established. MAMA, however, and all strategies have the potential for increased toxicity. The three main consolidation approaches being explored include high-dose chemotherapy with autologous chemotherapeutic cell transplant cell rescue, non-myeloablative chemotherapy, third, whole brain radiation therapy. And nearly all chemotherapy regimens included rituximab. Whole brain radiotherapy remains an alternative consolidation approach in younger patients, particularly those with contraindication, which has been shown to improve progressive-free survival compared with induction chemotherapy alone. And whole brain radiotherapy may improve outcome, but is associated with increased risk for neurological side effects in elderly patients. As you can see, the figures methotrexate given at sufficiently high dose to penetrate the central nervous system is the most active, single agent against primary central nervous stem lymphoma. And the addition rituximab high-dose methotrexate appears to improve overall and progression-free survival in patients with newly diagnosed primary central nervous stem lymphoma. Radiation therapy is an important treatment modality in treatment of primary central nervous stem lymphoma. These lymphomas are extremely sensitive to radiation therapy, but its use in the initial treatment of the primary central nervous stem lymphoma has waned over time as chemotherapy-based induction regimen have been optimized. These figures demonstrate the efficacy results of the study. Median overall survival was 32 months in the patient receiving full brain radiotherapy versus 37 months in those not receiving full brain radiotherapy, and median progression-free survival was 18 months in patient receiving full brain radiotherapy and approximately 12 months in those not receiving full brain radiotherapy. Update survival result after a median follow-up of approximately 18 months. Patient who received full brain radiotherapy had a significant improvement in progression-free survival and significantly progression-free survival from last high-dose methotrexate therapy, but without overall survival prolongation. And full brain radiotherapy, but neurotoxicity. Neurotoxicity is an important issue concerning full brain radiotherapy. Treatment-related neurotoxicity in patients with sustained complete response was more common in patients receiving full brain radiotherapy than in those who did not. And cognitive function and global health status were reduced in the early full brain radiotherapy arm as compared to the no early full brain radiotherapy arm. And minimal state examination testing revealed lower value in the early full brain radiotherapy arm. Drawback in the use of full brain radiotherapy in conjunction with chemotherapy for patients with primary central nervous stem lymphoma is the high incidence of cognitive worsening and white matter damage. The risk of neurotoxicity for patients aged over 60 years is unacceptable with this regimen. Neurotoxicity may present as rapidly progressive dementia that developed after variable delay from the end of combined modality treatment. This slide demonstrates long-term cognitive function in central system lymphoma. Patient radiologic examination showed diffuse white matter disease as well as cortical atrophy. Older age, mental status, changes at diagnosis, and radiotherapy predicted neurotoxicity. In order to decrease the toxicity rates, different radiation fits and reduced radiation dose have been examined. The study demonstrated that higher irradiation dose 40 gray were not associated with improved disease control compared to lower dose. Also, disease control was not significantly different with regard to irradiation dose to the tumor bed, while functional impairment as assessed by mini-mental status examination was significantly more common in patients treated with a full brain radiotherapy dose more than 40 gray. Thus, one can consider that consolidation with full brain radiotherapy 36 gray is advisable in patients with primary central nervous system lymphoma incomplete response after high dose methotrexate-based chemotherapy. Low dose full brain radiotherapy plus rituximab. This slide. Another study explored low dose full brain radiotherapy plus rituximab in primary central nervous system lymphomal patient. In that study, 200 patients were randomly in different in the randomly primary outcome was event-free survival with event defined as lack of confirmed or unconfirmed complete response at the end of protocol therapy or relapse. With a median follow-up of 33 months, event-free survival was similar between groups, and adverse events were similar between groups. Different radiation fractionation may influence therapy results. As a phase 1 and 2 study of methotrexate, rituximab and temozolomide plus hyperfractionated full brain radiotherapy in 66 patients with primary central nervous system lymphoma yield an objective response rate of approximately 86%. And among the patients before hyperfractionated full brain radiotherapy, and 46% of patients experiencing grade 3 and 3 toxicity attributable to post-hyperfractionated full brain radiotherapy chemotherapy. Cognitive function and quality of life improved or stabilized after hyperfractionated full brain radiotherapy. Indeed, the most important part of the radiation treatment is reduced radiation dose. Reduced dose full brain radiotherapy and sterabine were found to be feasible and effective after induction chemotherapy. This patient may achieve durable disease control associated with favorable neurocognitive outcome. Cognitive assessment showed improvement in terms of executive function and verbal memory after chemotherapy. One study compared reduced dose full brain radiotherapy with autologous stem cell transplantation following induction chemotherapy. The study found that performance was impaired on most cognitive tests at diagnosis. Linear mixed model analysis in each group showed statistical significant improvement from baseline up to year 3 in attention, executive function, graphomotor speed, and memory. There was a decline in attention, executive function, and memory after year 3 in both groups. Also, there were no significant longitudinal group difference in cognitive performance or quality of life. Which matter about abnormality increased over time in both groups, but more patients treated with reduced dose brain radiotherapy developed cortical atrophy and white matter changes. Other attempt regarding the toxicity of radiotherapy is to the use of stereotactic radiotherapy. In a study, patients who had recurred after full brain radiotherapy were treated with salvage stereotactic radiosurgery. Study demonstrated acceptable local control and survival rates after stereotactic radiosurgery. The median dose was 33.6 gray. Palliation with radiotherapy. Full brain radiotherapy is also a reasonable palliative option in patients who have contraindication to chemotherapy or relapsed chemotherapy, refractory disease, in addition to its ongoing role as an alternative to second-line chemotherapy in younger patients who fail to achieve a complete response to first-line systemic chemotherapy alone. On the other hand, full brain radiotherapy remains a reasonable salvage therapy in patients who have not responded adequately to induction chemotherapy or who are not candidate for chemotherapy. Radiation-induced neurotoxicity. Full brain radiotherapy radiation-induced neurotoxicity. The slide shows a summarized mechanism of radiation-induced neurotoxicity: tissue oxidative stress, vasculopathy, demyelination, depletion of progenitor oligodendroglobulin stem cells have been postulated. Prognosis. The prognosis is generally poor. Untreated primary central nervous system lymphoma has a rapidly fatal course. Survival increase with combined therapy. The most consistent prognostic factors are age and performance status. Conclusion. Finally, as a conclusion, primary central nervous system lymphoma is a common variant of extranodal non-Hodgkin lymphoma. Patients over age 60 generally succumb to higher risk of treatment-related neurotoxicity. The treatment success is closely associated with careful integration of chemoradiotherapy, considering disease control, survival, and treatment-related toxicity of primary central nervous system lymphoma patients. And the best treatment modality should be individualized. Thank you to organization committee for the invitation, and to you, dear participants, for your interest, and a thank you to my colleagues. Thank you.